So we'll be waiting for another 2 minutes for a few more people to join, and then we can begin at 6:05.
Sure, no problems. So in the meanwhile, can we talk about your organization? How is it helping the medical students?
Yes, sir. So basically, MSAI, Medical Students Association of India, is an organization by the students for the students, and it was founded in 2011. And today we have around 24,000 members from all states across India, and we are the largest medical student network in the country. And we are the NMO, or the National Member Organization of the IFMSA, which is the International Federation of Medical Students Associations, which is a global network of medical students. And how we function is that we have our 6 standing committees, through which we work on essential areas like public health, medical education, human rights, sexual and reproductive health, research, and professional development. So, all the members who have joined in today are members of MSAI.
Okay. Great. And how often do you have these meetings?
We have something or the other happening throughout the year. Every other day, we have one event or the other, whether it's through webinars, through on the ground events, or through online events.
Okay.
Um, we can, I think so. We can start now. I will begin with introducing Organ India. Um, Good evening, everyone. On behalf of MSCI and the team of External Affairs, I welcome you all to this exciting webinar on the groundbreaking topic, that is beating diabetes through simultaneous pancreatic and kidney transplant. And before we proceed, I'd like to briefly talk about Organ India, the organization collaborating with us today for this webinar. A project by the Parashar Foundation, a public charitable trust. Organ India is dedicated to promoting and creating awareness about organ donation and transplantation across the country. Since its inception, it has been actively working to bridge the gap in knowledge and encourage conversations around organ donation, making a meaningful impact on individuals and communities. And today, we are more than privileged to have with us Dr. Ashish Sharma, sir. And I would now request ma'am to introduce Dr. Sharma before we can proceed with the webinar.
Thank you so much, Saloni. And thank you, Professor Dr. Ashish Sharma, for joining us today. I'll tell you a little bit about Dr. Ashish Sharma, and I'm sure the rest he'll fill you in. Dr. Sharma serves as the head of Department of Renal Transplant Surgery at PGIMER Chandigarh. He is the founder secretary of the Pancreas Transplant Society of India and the managing trustee of the Organ Transplant Trust at PGIMER. Professor Sharma has played a pivotal role in establishing organ donation at PGIMER, and which has resulted in over 550 deceased donor kidney transplants. In 2014, he introduced pancreas transplantation at PGIMER and has since performed 55 such transplants, positioning the institution as the leader in this field within India. He also has tremendous academic achievements. He is part of the National Advisory Committee responsible for formulating guidelines on deceased donor transplantation and is actively involved with the National Health Authority. He has over 200 publications in esteemed national and international journals. Some of you may have heard the recent news where a 2-year-old Kenyan child, Prosper, had become India's youngest pancreas donor. Both her kidneys and pancreas were transplanted by Dr. Sharma and his team at PGI Chandigarh. So, Dr. Sharma, over to you.
Thank you very much. Thank you for the kind introduction, Sunana. And thank you, Saloni and Medical Association of India, for providing me this opportunity to talk to the medical students. Uh, we at PGI primarily deal with the postgraduates and the postgraduates. So our dealing with the medical students is almost negligible. So pardon me if my presentation is a little more technical, and I'll be happy to answer any queries in the meanwhile. I mean, organ donation, I'm sure that most of the medical colleges in the country, they do lack this facility of organ donation after death and transplantation, whereas it's one of the most challenging specialties, and many of you would find it as an upcoming career opportunity because of the tremendous growth potential it has in our country. So it is from that perspective, I think it is great to be associated with this specialty. And I'll be talking of something which is uh, very uncommonly heard in India. I mean, I think at the moment there are only 3 centers across the entire country which do pancreas transplant. So it's a very niche area, but at the same time, it gives you an opportunity to excel and get your name at the national field if you are able to work in this area. So before I start, I'll just tell you a little brief about my uh, the transplant program at PGH Chandigarh. So it started way back in 1973 when we did the first kidney transplant of the country, along with All India Institute and CMC Vellore. So these 3 institutes were the pioneers. And after that, it's been a steady journey. I mean, slow and steady. In fact, like the first 30 years was spent only on doing kidney transplants, and then we moved to start doing organ donations after death, which uh, involved more organs which can be donated and then transplanted. And a separate department was established in year 2005, and I'm sure that not many medical colleges would have the privilege of having a separate specialty of this regard. And we do about 300 kidney transplants a year and about 12 to 14 pancreas transplant every year currently. And we've got a large experience of these transplants happening, and we deal with all sorts of complicated surgeries involving kidneys, including auto transplants for Takayasu arthritis, where your both kidneys uh, arterial supply get blocked. So plenty of complicated work here with us. We do train people. We've started with the pancreatic transplant fellowships, so some of you might land up with this in future. And we recently started an MCH 3 years MCH program in renal transplant surgery. So despite being a very small department, we've been very lucky to have 3 alumni being awarded the highest national award. Professor R.V.S. Yadav, Dr. Sahari, and Professor Mukund Mins, and I owe my presentation to them because a lot of work in the background was carried out by them. So coming to the pancreas transplant, so I'll start with what is the normal glucose metabolism for your understanding. So this pictorial depicts that this is the blood and these are the cells here. G is the glucose, I is the insulin. So glucose and insulin travel in the blood. And for the glucose to enter into the cell, you have these channels, and these channels only open up when the insulin attaches to these black receptors. So if any of these gets upset, you land up with what the condition called diabetes. So they've got 2 types of diabetes. So for you to understand it better, so this is something what happens in type 1 diabetes. That is a complete insulin deficiency in the blood. There is no insulin production, right? And how it happens that at a very young age, the body's immune system starts to attack the islet cells in the pancreas which produce insulin. And once the islets are gone, there is no insulin in the blood. So if the insulin is not there in the blood, it cannot attach to the receptors. And if it does not attach to the receptors, the glucose channels do not open up; they remain closed, and there is hyperglycemia in the blood. Whereas the cells they starve of this. As compared to type 2 diabetes, which is a very different disease from type 1. So you got insulin in the blood, you got glucose in the blood, but the channels are still closed. Why? Not because there is an insulin deficiency, because the insulin cannot attach to the receptor properly. So this is a very crude presentation of the entire thing. Things are more complicated than this, but the receptor gets dysmorphed or by a lot of factors which we uh, call it as insulin resistance. And this problem is because of our dietary habits. We do not exercise well, and these receptors get desensitized. So as compared to type 1, there is insulin, there is glucose, but the receptors are faulty. So this is what is you need to understand between the difference between the two conditions. I'll just start with an example. So this is a lady who's 13 years of age. At 13 years of age, she presented with altered sensorium requiring hospitalization. And one of the common causes in this at this age group is called type 1 diabetes. When you presented with diabetic ketoacidosis, so she was a resident of Uttarakhand, and she was started on insulin. 6 years later, she had another episode of altered sensorium. This time, she required ventilation. In between, she's had multiple admissions for managing her infections. This is a photograph produced with permission. At that time, she's just got into nursing. And 5 years later, after this admission, she landed up with an end-stage kidney disease. So we know that diabetes is a bad illness, and it causes microvascular disease, and your microvessels get damaged at all in all the organs, namely kidney, your nerves, and your cardiac. So you got a triopathy, and she presented with end-stage renal disease. So so type 1 is different from type 2, that it affects the children at a very young age. Some of the children we've transplanted started with insulin therapy as early as 3 to 4 years of age. And these children are going to live for a long time. And type 1 is a very brittle disease as compared to type 2. Type 2, you can start with taking oral medicines and you can get a very good control, at least in the initial 10, 20, 30 years. Whereas type 1, you have to start from the insulin right away. And why I showed you that pictorial was, since the insulin is completely missing, the insulin receptors get hypersensitized, and any amount of insulin brings down the glucose very rapidly, and you've got very wide fluctuations in your blood sugar. One moment you may have a sugar of 50, you take some meals and the sugar may just go to 500, you take insulin and then again it drops to causing severe hypoglycemia. So it can affect your kidneys, your eyes, and your nerves, including other problems. If it involves your vessels, it can lead to amputations, your cardiac disease, and definitely lead to premature death. India has got a huge burden of type 1 diabetes, and most of them do not survive because once they end up with an end stage disease, they have already spent considerable amount of money to for taking care of all these illnesses, and there is no facility to take them further for transplant. And there she was started on hemodialysis at 26 years of age. She did not have any facility at her local PHC where she was employed, so she had to leave her job. And so this is a graph, survival graph. I'm not sure how many of you would be looking at these, but just to explain these, that there are two lines. The top two lines, there are actually three lines. The top two lines are the survival figures after pancreas transplant, and the third one is those patients who could not get a pancreas transplant. So this is the time spent in years, and if we start with 100 patients at point 0, so if you see that by 2.5 years, by 2.5 years, almost 25% of the patients who were waiting for pancreas transplant have died, and at 10 years, only 25% of them survive. And if you are able to get a pancreas transplant, your survival is considerably better, in the sense that almost 75% of patients are living at 10 years. So these figures are from United States, which has the largest experience in pancreas transplant. And So this is how she was, that she could get a pancreas transplant with us in 2018. She had some complications related to dengue infection, but she recovered with a normal kidney and normal pancreas function, and she could get back to her PHC in a very remote location only because she could get a transplant which was completely functional. As with any girl, she wanted to marry and she could get married in 2021. She had a normal pregnancy, completely and uncomplicated, and was widely covered at the time of childbirth by all uh, print and electronic media. And the child now is more than 4 years old. And so coming to the question, so this was a classical example of a patient who develops type 1 diabetes at a very young age and deals and is able to come through all the complications of diabetes successfully based on pancreas transplant, and could lead a normal life based on her job as well as her other social and societal functions. So coming to the next question, why do we need a pancreas transplant? I think the case has demonstrated. In whom can it be performed? What are the expectations of after pancreas transplant? The types of pancreas transplant, the global experience, and why is India lagging behind in this field, and what can we do with it? So types of pancreas transplant. Somehow I think it's not coming on my screen here. So okay, so I think so. Normoglycemic state is what is required to prevent complications of hyperglycemia. And normally, normoglycemic state can only be achieved with pancreas transplant. If you try to do it with your insulin or with your oral hypoglycemics, you increase the patient's burden of day-to-day diabetes management, which means that you will have more hypoglycemic episodes, you will require a tighter control, you will require more intensive insulin drugs and all. And it's rather impossible to many patients. And the only way to have a sustained normoglycemia, even in the current era, is with the whole organ transplant. You can do a beta cell replacement therapy only, where you can only isolate the islet cells from the pancreatic pancreas. You can actually get the whole organ out and digest the rest of the cells and take only the islet cell and infuse them in the portal vein. They work, but not as good as the whole organ transplant. Currently, the technology has advanced to continuous glucose monitoring, where you can actually have a sensor which can continuously perform your glucose levels and can keep on delivering those results on your mobile. The technology has further advanced that they can have a closed loop system where these inputs from the CGM machines can be given to insulin pumps, and which can actually regulate your insulin delivery based on your glucose values. So which actually what we call is an artificial pancreas. But these technologies are still limited in the way that they still cannot replace entirely, and you still are not you do not achieve the completely normoglycemic state. This is a very typical curve. What you see at the top half is before the transplant, and the bottom one is after transplant. If you see those, there are wide flings and wide swings in the blood sugars before the pancreas transplant. This is very typical and characteristic of type 1 diabetes, where your receptors are hypersensitized, and any amount of insulin can produce a rapid fall in blood sugars, and you are dependent on exogenous insulin completely. And as compared to the state after the transplant, where your sugars are completely normal, and this is what actually is important to prevent any subsequent complications of uh, diabetes, uncontrolled hyperglycemia. The types of pancreas transplant are, so either you can do a kidney and pancreas transplant. This is the most common one used. This is mostly for patients who have uh, developed kidney failure, like the case I demonstrated. So the time when you end up with the complications, you can do a pancreas after kidney transplants because pancreas donations are limited. We do not, if you do not have a active disease donation program going on, so you may not be able to get both pancreas and kidney at the same time. Remember that pancreas can only be transplanted after donation after death, whereas kidneys you can actually get from donations from the living donors in the family or otherwise. So kidney transplantation is much more common as compared to pancreas. But if you had a kidney transplant after type 1 diabetes, you can still get a pancreas uh, transplant afterwards. We can't do a pancreas transplant alone in the first place, that you do not land up with any such complications. But these transplants do not happen primarily because you got too many people waiting for simultaneous pancreas kidney transplant. So, and we do not have enough number of pancreas donations so far. So if we see the pancreas transplant activity across the world, so US does close to 1,000 donations and 1,000 transplants every year. The activity peaked in year 2005, and so when it touched a figure of 1,400 transplants. So US is about a third of in about one third of population in terms of our country. So we should be doing close to 3 to 4,000 transplants every year. But you will be surprised to know that we've done so far only less than 200 transplants in the entire history of pancreas transplant in our country. So coming to the survival figures, so that's the most important thing. Whatever you are doing, what is the impact of it? So this is over a period of time, that if you see that the pancreas transplant started in the 1970s across the US, and at that time the 1 year survivals were very low. And there are 4 graphs here. So first one, the top one line is the simultaneous pancreas and kidney transplant, and that tells you what the kidney graft itself, right? So the highest survival throughout all this era is for the kidney graft. The second triangle, the blue triangles, tell you about the pancreatic graft for the simultaneous pancreas and kidney transplants. Pancreas transplant typically have a higher incidence of complications, so that is why their survival is poor, worse from to begin with only, and that difference carries over throughout these years. So if you do a pancreas transplant alone, or if you do pancreas after kidney transplant, so in both you are doing only pancreas transplant, and their survival figures are worse than combining the two organs together, but they are now very close to the pancreas graft survival as seen in SPK transplant. And these are the 5 year. This is a 5 year graft survival. So this is over a period of era. These are from the early 70s, and this is from 2008 and 9. And the survival figures now touch close to 90 at 1 year, and at 5 years as well. We're talking about the India. So far, less than 200 transplants across the country, and we're proud to inform that like we've done a fourth of them. And apart from them, there is a center in Chennai, the Apollo Hospitals, which is no longer doing these transplants. There's a center of in the Institute of Kidney Disease and Research at Ahmedabad, who is the second one. And there are a few private hospitals in Karnataka, mainly in Bangalore, which are also doing. And a couple of other centers across the country have reported, but none of them is actually doing a pancreas transplant on a continuous basis. So at the moment, you got 3 main centers: PJ Chandigarh, Apollo, IKRDC, Ahmedabad, and there are private chain Manipal hospitals in Bangalore who are doing these pancreas transplant. So this is the pancreas comes only from disease donation. So to start pancreas transplant, you have to initiate disease donations, and that is why education and awareness amongst our medical fraternity is most important, because they are the ones who actually would be involved in counseling and identification of these donors in an intensive care setting or in a surgical setting. So before 2005, there were no donations happening in our center at PGI. When we started a thought process, we conducted a symposium in organ transplant, and that is how we could actually start the donation process. So from a total barren land, we could actually reach up to 40 to 50 donations happening every year at a single hospital, which was thought to be very good. And then slowly and slowly we could start the liver transplant program, a heart transplant, and 2014 we actually ventured into the pancreas transplant program. And this is the data showing how we fare across the country. And if you see that the transplant program across the country picked up only in over the last decade or so. So, and over the years, we've been doing most of the pancreas transplant across of the country. So nearly half of them have been done by the PGI in most of the years. And this year we probably have touched the highest so far. This is probably an older slide. So we've done close to 15 transplants this year so far. So total of 54 patients. So if you see that the mean age is about very young, 30 years only. So they're in the prime of their life. And if you don't transplant them, most of them would die within a couple of years. And most of the patients have been struggling with type 1 diabetes, although we've now started to do transplants for type 2 diabetes as well, because again, there also you get a benefit in terms of insulin independence and no need for any monitoring. The donors have been fairly young, in the sense most of them were road traffic accidents and young males, majority of them with a mean age of 28 years. Although we've, as Sunana pointed out, that our youngest donor is possibly amongst the youngest in the world. So that's for 2 years of age, and we've gone up to 49 years of age. And these are the outcomes. If you see, I have split them into 3 eras. So, and that actually partially tells that why pancreas transplant is not being commonly done across the country. The first era, first 3 years were quite struggling, that we've had plenty of surgical complications. If you see that we required re-explorations in most of our patients, we had to take the pancreas out. And despite that, and with all these, we've had some mortality as well. But if you move to the recent era, we see that the re-explorations are now less than 10%, which is an accepted figure across the world. And with the majority, 90% of the patients achieving insulin independence, which is same as the data I showed you in the slides. And the results keep on improving with the gaining experience. So future of pancreas transplant, I think it's bound to increase. At the moment, the activity is restricted to 3 centers, but as we train our more and more surgeons, I think more centers are going to pick up, and they are the ones only who having a already established diseased donor transplant program. The outcomes improve as the experience grows, and so having building teams and mentor programs helps to establish these programs across different centers. And we need to develop a transplant training program in the country, so which we've already done. And I think the bottom line of any transplant program in our country, India lacks in terms of organ donations. So at the moment, the diseased organ donation of rate of India, which is calculated in per million population, stands at a decimal 0.8, right? So less than 1 million less than 1 per million population in the entire country. And if you compare with the best in the world, it is at 50. So we have to grow that 50 times. So that is the potential, and maybe we need to exceed that, as we have done in many other areas. And for that to happen, we need a lot of medical professionals entering into this transplant and donation programs to make that happen. With that, I think that was the last slide. Thank you very much. All that requires a great team effort, and we're fortunate to have such a team here. And with that, I would like to invite any questions, any comments for this.
Thank you so much, sir, for that insightful presentation. We do have a few questions. Um, Participants, if you all have any questions, you all can drop it in the chat box, or you all can raise your hands. Dave Chabot, you can go first.
Good evening, sir. I hope that I'm audible.
Yes, please.
Sir, in the beginning, you mentioned about a graph of 1 year and 5 year survival rates of various types of pancreas transplant. So the top two were occupied by pancreas graft and the kidney graft. So when we are talking about simultaneous transplantations of both pancreas and kidney, what does this entity, pancreas graft and kidney graft, actually refer to or mean?
Yeah, so that's a good question, and somebody amongst the audience who's very keenly observing would only pick it up. So thank you, Dave, for listening to my presentation. So when we do pancreas and kidney transplant together, so pancreas part has got more complications in the sense that it is more prone to get thrombosis. If you can recall from your physiology that your kidney has got a flow rate of nearly 1200 ml per minute as compared to pancreas, which is about 100 200 ml per minute. So that is why you tend to have more thrombosis, so more pancreas come out. So traditionally, that surgical complication rate, excess surgical complication rate for pancreas transplant is about 10%. So that is the difference between the two. So your pancreas outcomes are always inferior to kidney outcomes. I hope that makes you.
Yes, sir. Thank you so much. It does make it clear.
So we've got a few more questions. I'll read them out. If,
Yeah, please.
can you please share what inspired you to take this profession and this particular stream of transplant surgery?
Yeah, that's again a very personal question, but I'll definitely like to reply to it. Actually, so I belong to a family with the history of polycystic kidney disease, right? So I've seen my elders dying from kidney failure, right? In the 1990s, in the early 2000s, transplant was not so common. So that actually motivated me to take up the specialty. And when I joined this, we saw that the kidney and the liver transplant programs picked up very well across the country. And in fact, like liver is, we are almost in the living liver transplant. We are almost leaders in the world. A lot of people actually come and get trained here. But the pancreas was not picking up at all, right? So then we thought that if we need to do this, we need to establish this in the country, and we that's how we got motivated, and now we are there, and I'm sure that we in the next few years we'll be the leaders in the world as well in this area.
Yes, so like you just said, in the coming few years, we'll be able to do a lot more transplants that are happening currently. So, how can we make organ transplant in India more accessible and more affordable?
Accessible and affordable. So accessible can only be donations, right? So there we need support from the entire medical fraternity and entire public. So so we do, I mean, our country at the moment does not believe in organ donation, right? So we have an organ donation rate of 1 per million population, right? And part of the problem is with the community, but the majority of the problem is with our medical professionals, that we are not able to counsel these patients in time for organ donations. So if they're in the ICU, I mean, it's very hard to believe it, but this is what actually happens, that they are in the ICU, they are not prognosticated accurately at the given time, and they are not given an opportunity, and they're not declared brain dead, so they're not given an opportunity to donate organs, right? So that problem is with our medical fraternity. So if we can take care of these problems through education, I think, I'm sure yes, public would be forthcoming to donate organs. Accessibility can be resolved. Affordability is a greater question, so it needs to be addressed either through assistance through the government funding, which some part of is already happening through the Ayushman Bharat scheme, that the kidney transplant is now being funded through it. And second can be answered through research. If we can develop the medications are the ones which are more expensive, and the transplant operation itself is not an expensive affair. So I mean, if you think of the surgical part only, so I mean, we can probably do it in 30 40,000 as with any other surgery. So there are no cost with the operation itself, but the medications are the ones which are more expensive. And so a lot of research is actually going on in the area where to develop such protocols where you do not need to give lifelong immunosuppression, or you modulate the organs in a way that they do not express any HLA antigens. So that's an active area of research, and if you can make a breakthrough in those, so I think probably we can do it.
Okay. So I think ma'am has a question. Ma'am, would you like to go ahead?
Yeah, hi. Yeah, so you said there are very few pantries available for transplantation. So since we have, say, about 1,000 organ donations in a year, why are fewer pantries available? Shouldn't there be more
Yeah, so
available?
that's another very good question, right? So India does now about 1,000 donations per year, and that's what makes it higher. That's what makes the rate to be about zero point 0.8 per million population, right? For a population of 1.4 billion, so we are doing 1,000 donations, but we're doing only less than 50 transplants, pancreas transplant every year. So part of the problem is that there are not enough trained manpower. So pancreas are not routinely offered for donation. Also, like there is a national organ sharing program where you are supposed to share organs for transplantation if you do not have any local uh, facility or local recipient or local expertise to transplant that particular organ. The heart is offered, the lung is offered, the liver is offered, but there is no there's still lack of information or lack of this thing about the pancreas. So pancreas is not offered. So and at the moment we were only doing pancreas which we were getting in house, right? So we have a donor at our own hospital, so we were actually utilizing only those pancreas. This year, this is the first year when we started going outside our hospital, so we actually could procure three pancreas, one from Jodhpur, one from nearby city, and one from Rishikesh outside. So we could procure. So maybe as time progresses, we can venture more of these. The second more concern is that pancreas transplant is best when it is done with the kidney. So a lot of people actually uh, do not want to share their kidney, right? So they're willing to share the pancreas, but they're not willing to share the kidney along with the pancreas, because that those states or those colleges still have a person who can be given a kidney. So I think these two issues need to be sorted out at the national level so that we can actually move forward. And maybe the best would be to have local teams. So if there's a local team who can do a pancreas and kidney, so then I think that problem will be sorted out.
Okay, thanks.
So we have more questions in the chat box. It says that why was the mortality higher for pancreas alone transplant versus the SPK transplant?
So it is not that the mortality is higher after pancreas transplant alone. I think probably the graph I showed was that the earlier period, the 1970s, your rates were very poor. The mortality rate is the same whether you do a pancreas transplant alone or you do an SPK, but your outcomes, your graft survival, the chances of pancreas functioning are significantly worse with they used to be significantly worse with the pancreas transplant alone as compared to simultaneous pancreas kidney. Part of the reason was that when you were doing a kidney transplant along with pancreas, you got something very easy to monitor, that you got a serum creatinine measurement to monitor, and you can get a urine routine to monitor those. So the monitoring was is very easy. Whereas with the pancreas transplant, even very tiny amount of islet cell will keep on producing enough insulin, and in the end they'll just give way. So monitoring is more challenging, and earlier with less in the earlier era with the less effective immunosuppressive regimes, the pancreas used to die out much earlier.
And so there is one more question that says, what are the common complications of pancreas transplant alone and how are they managed?
So pancreas transplant is challenging in the way that you are transplanting not only the pancreas, but you also transplant part of the duodenum, which is surrounding the C loop of which is surrounding the head of pancreas, the C loop of the duodenum. Pancreas is a very low flow organ, right? The flow rate is hardly 100 to 200 ml per minute in the pancreas. So thrombosis is very common. Pancreatitis is very common. In fact, some pancreatitis is bound to happen. When we enter the MS surgery, so we are always taught, you do whatever you want, but never go near the pancreas. They're so scared of the pancreas, right? Here we are actually taking it out, fiddling it in the ice, and then putting it back. So pancreatitis invariably happens, and these pancreatic juices are so rich in amylase and lipase that they'll digest everything whatever comes their way. So you got a lot of GI complications. So all those can be managed. I mean, all those can be prevented. Actually, managing is very challenging, very difficult, but you can prevent all these complications. For preventing all these, you need to minimize the insult given to the pancreas. So if you're very good and gentle in your surgery and follow all the protocols, then your outcomes are great.
Thank you, sir. Um, the next question is there a possibility in the future for development of artificial organs to be utilized for transplants?
Yes, I mean this word has been doing it for the many years. So there are three streams of scientists which are working in this area. One are the ones who are working with xenotransplant, and I don't know whether you're aware or not that last year they could actually successfully use pig organs to humans. So they did a pig heart transplant, and they did two pig kidney transplants in the US. And there was one report of pig liver transplant coming from China. So how truthful is we don't know, but the US reports are definitely true and were widely published. The second stream deals with the stem cells that you try to regenerate those organs. So I think a lot of hype was created, but that's more or less fizzled out at the moment. And third stream is to working on the organoids, that you have cells, you have the embryonic cells, and then you cultivate them into organs, and then you transplant them. So that is still in a very native stage, so very early stage. So we not sure how far will it reach. But the one xenotransplant is almost a reality, that if you want an urgent transplant, and if you only want for some period of time, so it can actually act as a bridge to transplant for somebody who's in a life-threatening state. The rest are still to be developed.
Okay, I think we are done with the questions, sir. Thank you so much for such an enlightening presentation and a very insightful Q&A session. And on behalf of MSAI and Organ India, I would like to extend our heartfelt thanks to Dr. Sharma for taking time out of his busy schedule and enlightening us on this topic. And it was truly an eye-opening session. Thank you so much to Organ India for partnering with us and to all the attendees for your enthusiastic participation.
Thank you very much for giving an opportunity to share my experience with you all, and I hope that it benefits you and it benefits the organ donation and transplant program. And thank you very much, Sunana, for always in getting me connected to the youngsters to give these talks and to motivate them to join this specialty to bring India on the international map. Thank you very much.
Thank you so much. Thanks, Saloni. Thank you, MSAI. And thanks everyone for joining.
I would request the MSCI